Дорогие коллеги, меня зовут Агзам Шаймарданович Жумадилов. Я доктор медичных наук, профессор, голова Казахского товариства анестезиологов и реаниматологов Астана, Казахстан. Dear colleagues, today we consider prediction tools that may help highlight obstetric patients at risk of critical illness, maternal early warning, and scoring systems to aid in detection critically unwell parturients and recent update to obstetric critical care governments. My presentation виявлення та познавання тяжкохворих породіль. Pregnancy is a normal physiologic process with the potential for pathologic states. Pregnancy has several unique characteristics, including uteroplacental interface and physiologic traits that can cause pathologic states to develop, and a maternal fetal interface that can affect two lives simultaneously or in isolation. Critical illness in pregnant women may result from deteriorating pre-exciting condition, disease that are coincidental to pregnancy or pregnancy-specific condition. Unfortunately, this critical condition can lead to cardiac arrest and sometimes death. Recognition is first and crucial step. If we recognize this condition early and take rescue measures, we can avoid cardiac arrest and deaths. Critical illness often involves multiple organ failure and is associated with significant morbidity and mortality. In the vast majority of patients, there is a recognizable period of physiological deterioration which herald the development of organ failure and the critical illness. Despite efforts to improve the detection and management of critical illness, signs of deterioration are often missed and decisions to move patients to critical care units are delayed. If we recognize this condition even early and take measures to save ourselves, then there will be further complication, and the results of managing pregnant women will be even better. Tools for early recognition can easily reduce mortality and morbidity. Examples of early recognition tools for obstetrics: comorbidity-based risk prediction systems can identify previously undetected high-risk patients during the antenatal period. They can assist in the clinical and operational planning of appropriate care by facilitating decision-making before clinical deterioration occurs. Some of the more widely available prediction tools are considered in slide. Why maternal or obstetrics tools need? Simple and accessible vital things: blood pressure, heart rate, respiratory rate, and saturation. They help to identify causes of morbidity: obstetric hemorrhage, sepsis, hypertensive and cardiopulmonary disorders. Types of early recognition tools: single parameter trigger type, scoring type, pathology specific type. Single parameter trigger type, example maternal early warning criteria. including blood pressure, heart rate, respiratory rate, saturation, urine, headache. And if abnormalities are detected, evaluation by a doctor, emergence, diagnosis, and therapy. Scoring type, example, modified yearly obstetric warning score. Maternal yearly warning score has been recommended in the UK Science 20 and 11. With scores less than 2, maintain current plan, 3, 4, repeat assessments, 5 or more, ICU admission. Scoring type score, news 2, national yearly warning score, 1 for low, medium, and high, 7 or more emergent assessment by a clinical team and usually transferred to ICU. Pathology-specific type, example, California Maternal Quality Care Collaborative. Criteria to activate hemorrhage protocol, heart rate more 110, blood pressure less 85, saturation less 95, shock index more 0.9, and initial sepsis screen, temperature, heart rate, respiratory rate, positive if 2 or 4 criteria met. Pathology-specific type, screening among patients with infection, quick SOFA score and them SOFA score assessment. Conventional survival sepsis guidelines are followed with junction fluid therapy. Obstetrically modified quick SOFA score for us, systolic blood pressure less 90, 100 in non-pregnant patients, respiratory rate more 25, 22 in non-pregnant patients, alternate maintenance. Among patients with PPH, clinical things that may indicate beginning or undetected PPH within 24 hours after delivery and should activate close and active patients monitoring. If patients at risk, close and active monitoring. Delays in the detection or treatment of postpartum hemorrhage can result in complications or death. Emotive trial was an international parallel cluster randomizing trial. The interventions included a calibrated blood collection drive for early detection of postpartum hemorrhage and abandon. First response treatments, uterine massage, oxytocin drug, tranexamic acid, intravenous fluid, examination and escalation. Early detection of postpartum hemorrhage and use of blended treatment led to a lower risk of the primary outcome and composite of severe postpartum hemorrhage, laparotomy for bleeding, or death for bleeding. That usual care among patients having vaginal delivery. Coagulation management and transfusion in massive postpartum hemorrhage. Basic precondition, normal temperature, pH more 7.2, use training summit, I think, point of care and laboratory test, initiate transfusion protocol until diagnosis available, and target hemoglobin, platelets, fibrinogen levels. Which is the best tool? No best or universal tools. Choose and customize a tool in each facility. Consider facility resources, patient's characteristics, tool performance. Implementing maintaining of yearly recognition system, understanding of importance of yearly recognition, routine vital signs checks, understanding trivial criteria, and provide simulation training. Case scenario-based simulation course, yearly recognition of critical ill, and start initial therapy. Japanese simulation course algorithm, critical triggers, no response to pain, shock index more 1 and bleeding, shock index more 1.5, saturation less 95, respiratory rate more 25 or less 10. Low level facilities, call ambulance to transfer patients. High level facilities, call emergency room, ICU, anesthesia, and operating room, and start initial therapy. Define, quantify risk bleeding volume, diagnosis cause of bleeding, coagulopathy, blood replacements, avoid dilution, hypothermia, acidosis, start fluids, protocols, each hospital no universal recipe, and prediction, sick patients, and progression PPH. Need teach, analyze, and simulate, use procoagulants when needed. Yearly recognition of critical ill Parturients is important. Use and yearly recognition tools. Choose and customize a tool for your facility. Maintain knowledge and skills for yearly recognition by regular trainings. Дякую за увагу.